So Kathy and I are going to moderate this last session and kind of maybe try to pull this all together. And thank you, Reed, for kind of giving some context and kind of as we think about the broader perspective. And what we really want to do with this panel at the end of the day is to have some really short but concise ways to give us some recommendations, suggestions for the roundtable related to what we do next and opportunities and solutions and suggestions. So one of the objectives for this panel was to identify potential solutions to overcoming barriers in access to genomic medicine and actionable health issues related to healthcare disparities. We've been talking about it all day. And so what I ask each participant on the panel, if you could just take 2 to 3 minutes and talk about what would you recommend the roundtable do next, or what are the issues that the roundtable should follow up on as they tomorrow have a meeting where they'll start to explore what's next with regards to this topic area and the work of this important roundtable.
I guess, but that was a really tough act to follow because I think that the last speaker, Dr. Tuxen, really got to the heart of it. And I feel like as a society, there's a lot we have to decide. And one is, are we going to invest in this? I mean, we've already invested in it, and some of that's been driven by, companies investing in it. But there seems to be a lot of enthusiasm for delivering on the promise of personalized and precision medicine, but there's so many challenges against it. And as we get more personalized to the point where we're an N of 1, then we all become more vulnerable. So, and less likely when we start looking at population-based recommendations and guidelines for screening or genetic testing or implementation to not fit into those categories. And so I think we have to kind of back up and say, okay, as a society, are we really invested in precision medicine in the way that we need to be to, make it equitable and really start making sure that everybody has access to the things that, they need to get that, that equity, because we all have different risks for disease, and maybe we really need to move away from population-based guidelines when we're having this conversation, or at least starting to turn toward, are there ways that we can actually save money in one realm to spend it in another realm? It seems like a really giant challenge, and I feel like there's a lot more intelligent people in this room that probably can speak to how we approach this and what we do next. So thank you.
Well, again, being a community-based person, I think that having the patient perspective like we did this morning, I think was just profound for me and for many of the people in the room. So if we can have more participation from people that have gone through the process of having genetic testing or screening, and so that they can share what it is that they experienced and what they need, and also inviting people from the community. So some of these community leaders to talk about, what has worked, what doesn't work, what they feel would be instrumental to help the communities that they serve. So I think having more diversity in our meetings, not just having all academics, but also bringing people in from the community. So I think that would be a good next step.
Well, first off, we're talking about a number of different things here. One is population screening to identify people at risk. Another is testing, diagnostic testing of people who have already been identified as having a disease to see if they have a gene mutation or genomics that modifies their disease or determines how their disease should be treated. They're two different things. In both instances, we talked about the U.S. Preventive Services Task Force earlier, and I pointed out that their federal law says that they look at the data and they make recommendations about people in the general population, not about people at high risk, but people who are of average risk. Perhaps one of the things that we need is a U.S. Preventive Services Task Force specifically to look at screening of people at high risk. And that group would do the same thing the task force does. A literature review to figure out what the science actually says, sit down as a grand jury, and ultimately write a statement. Everything that we do in medical oncology, I still practice medicine, and we do it by what are called NCCN guidelines. We have a group of folks, they're based in Philadelphia, and they get together people who do prostate cancer, and they say, let's write the rules on how you treat prostate cancer. They get together people who treat lung cancer and do the same thing for lung or breast or what have you. We don't have that for screening in terms of genomics. We don't have that for treatment in terms of genomics or determining people at high risk for their particular type of genomics. You occasionally, with NCCN, will have them say that a Taylor RX, like I talked about this morning, ought to be done on women who have a particular type of breast cancer. But even then, there's 135,000 women who are going to be diagnosed with breast cancer this year that should get a genomic test, and I know that 60% will. The other 40% will not because it costs about $4,000. So we already have rules that say they ought to be treated. And the next thing, and I said this at lunch, I think everybody needs to think about this because in the United States, we are terribly guilty of not practicing evidence-based medicine. This organization in 2010 published a paper that said 30% of all medical costs in the United States are either waste or fraud. The United States spent 18 cents out of every dollar last year on health care. The next most expensive country was Switzerland, which spent 12 cents out of every dollar on health care. I, as a chief medical officer, like my friend from the University of Michigan, have to negotiate health insurance for the employees of the American Cancer Society. Our average cost for health insurance this year is over $19,000 per employee for a family. And there are these projections that have been published out there that look at the cost of health insurance in the United States over the last 30 years and median family income over the last 30 years and just draw the lines out into the future. And it's between 2035 and 2040 when the average cost of a private health insurance plan in the United States and the median family income are the same number. Translated, it's just a short period of time from now where half the families in the United States cannot afford insurance. So we got to be very careful in what we're doing here and not raise costs. We need to do things. By the way, the Taylor RX thing I talked about this morning, that's $4,000 for a patient, and it can potentially save that patient about $60,000 to $80,000 in chemotherapy. It's one of the few times I can actually tell you there's a test that saves people money. We got to be very careful. We have to, I'm sorry, I'm in public. We have to be very careful that we do things with an evidence base. And I really do think the thing to do is get these judges and juries together to look at the science and actually say these are the rules under which we should be practicing.
Thanks again for the opportunity to come speak. I'm kind of passionate about population health and quality improvement, and as I've been listening, I've heard lots of opportunities that we have to optimize the care that we're giving and a lot of the barriers. So this issue of disparity, and again, I'm talking about screening populations. If we require that people have insurance and that they have a medical home and that they see their provider and they share their family history and they get a referral and they attend the referral and end up face-to-face with a genetic counselor before they have access to some of these new developments we have in internal medicine, there's going to be progressive disparity and more attrition. And so when Dr. Armstrong shared, she said, if we're looking at population health and access for health, we have to figure out that piece of when we want to provide some of our genetic tests or genomic medicine to populations and how we can make that available to people that doesn't involve all of those steps, because there's just progressive attrition there. And more disparity. And the other thing is, so that's one question. Can we look at the aspects of genomic medicine that should be used routinely in population health and make that accessible such that it there's not all of these attritions to get to that. The second thing is that you get a diverse workforce. You take care of diverse patients with a diverse workforce. And what that looks like in my community is we hire people who are bilingual, who start at front-level positions, and they become medical assistants, and then they become RNs and go to medical school. And so bringing into our workforce, and it's our patient navigators, they're not expensive people, but they have all of this bilingual and cultural expertise that we can bring to bear. So is there a role for a health educator in providing genetic counseling at point of care at places where people are getting mammograms and pap testing and fit testing, and this can really decrease some of those barriers. And I think the workforce ourselves, the health providers, are acting as more of a barrier. We're so anxious about shared decision making and potential risk that we're opening up for patients that we're hesitant sometimes to provide this to our patients. So we really need to have some comfort about letting things go and letting patients sort of access what they need. I think we can also save money and do less testing if we mindfully implement this. And there's not a lot of evidence right now that if I provide this level of stratification for my patients, I can reduce the cost to my health agency by doing less. And we should encourage our providers to do less.
Three specific points. Number one, as I indicated with this, I think we've got to get at this notion with the K through 12 education. And so I think we ought to be partnering with the science teachers associations and really working very intensely with them to get this right. I think we have an obligation to do. Otherwise, we'll just continue to be trying to sub-optimize downstream. Number two, I think in addition to your friends at the Guide to Clinical Services, we ought to reach out to the Guide to Community Preventive Services and get better information from them on the guidelines on how to have the conversation about trust. How do we go out into the community and work hard to say, for our catchment area, for our population, we're going to have conversations with you, listening beginning first, but we're going to have conversations with you that over time, no quick thing, 5 years from now, you will actually believe that the people here have your best interests at heart and that we're in this together. And third, because we are just as dumb as we were before and the science progress is increasing at exponential rates, we're going to have to work with the people who develop the EMRs for just-in-time learning. We're going to have prompts. Nobody is smart enough to remember this stuff in their head. It's going to have to be where the patient comes in and the information that you need to be intelligent and have that dialogue is right there in front of you at the point of care. And I think those three are fundamental keys for right now.
So can I push you guys a little bit harder? And Catherine and Reed, just because, what do you think, how can we as the round table help specifically with those initiatives? We have, our Public Health Genomics Action Collaborative that Meween can talk about. We have some of these going on. But, how do you see our organization really moving the bar on this?
Well, from my end, I'll tell you, I've met with the schools, so I've done it, and I've said to them, look, it's just me. I mean, nobody. I ain't got no nothing. Just hey, And what I said to them is this, is you got to teach math anyway. So you got to teach something. So why don't you teach BRCA 1 and 2 decision making as a case study for the math or for the statistics course? Build it so it's not like it's this other thing. Go center core. Here, we'll give you 5 case studies of genetic decision making that you can put into the curriculum to use for your economics course, your whatever it is that you're doing, but it'll basically be the statistics thing. So I think it's easy. That's just because I know we don't have much time to get to the audience. So I just say that's one thing you do is now you take the roundtable, goes and convenes the 3 science teachers organizations, about 3 major ones, and you just say we want you to come in and we're going to have a partnership for a long time. We're joined at the hip, and by the way, we're here to help.
So just briefly, I'm working with Caesar and the NHGRI to do exactly this, to take 2 online tools and go to our patients and screen them online and offer testing. And there's a lot of, again, anxiety in our community that we may be causing harm, and we need to do all sort of this risk management, and we need to have these detailed conversations. And so there are ways in which we can deliver genomic medicine to patients at risk that are that do not involve increased risk, if we can do this ethically. And currently we do, and make sure that we have a downstream management plan in place, and that I think it, from my bias as a family physician, is involving people in a medical home and their community. So answering that specific question of what aspects of this is it safe to bring, is it appropriate to bring to all populations, so that we may not need to have all of these assessments and barriers in place. That might be a bar that we can lower. We're already sending people for prenatal testing. We're already routinely doing mammography testing, that without any thought, this is just part of the routine health. So how do we bring genomic medicine into core services that we just expect for our population? And that question is not answered yet, because we have all this anxiety about it.
Kathy, I'd also like to suggest to making sure that the interventions themselves, I said this earlier, but that the interventions themselves are covered and that people understand that. Because if you deliver them a test that tells them they're at higher risk or that they qualify for a drug, and they don't have access to the drug or the screening or the risk reduction, then they're going to say, why should I do this? So I think that's important.
Great, thank you guys so much. I would want to open this up to our Muine. You're ready to go. Open it up for discussion and comments. And Jeff, now how do I choose here? You're the chair of this, and he was up there first. So Jeff.
Thanks. So I just have a comment, and this has been great. I want to pick up on Vince's question about what the roundtable could do, and Reed, at the end of your talk, you basically called on us to support the All of Us research program, but then you paused and said, well, we don't really know about trust, we don't know about informed consent, we don't know about a lot of issues, and I think this will be a total failure if we have 1 million middle-class white people in the All of Us research program. So how do we use that as a platform and really to be a catalyst for changing the way we engage the underserved minorities and other groups in genomic medicine research? And that will go a long way. So can we, as a roundtable, begin to work with the All of Us research program and begin to really build the education, the understanding of things like informed consent, the data security issues, all of these aspects of communication that will really enable us to have a truly representative population in that study?
Very briefly, I think, that, at one level, I'd sort of talked about this at the macro giant scale, but let's take it, but what I was getting to with my last comment is that one of our previous speakers talked about her relationship with the churches. So she's already in the churches. She's already put hard-earned effort into that. So let's recruit from that church. Each one of you in this room have spent time with your clients, your patients, and you have a core of people that you have established that relationship with. So at the macro level, we have to work with the Urban League, the National NAACP, the Black Baptists, all that at the macro. But that's hard. we got to do it. It's hard. But what we can at least do on the short term is go ahead and self-deputize ourselves to get those 30, to get those 10, get 5. I mean, it's 5. If we just keep doing that, and all of your professional relationships can find 5, then we start to at least get close to that number. So, big level, but also we don't wait for the whole big level. Let's take care of our little corner of the world and grab the people that we can.
Okay. Initially, I wasn't going to say anything, but Reed put me up to it. So here I am. So thank you all. This has been an amazing day, and I was taking furious notes in between my tweets. So anyway, just wanted to ask want to say a few words and then ask a question for the group. So the context of genetic exceptionalism that Greg raised as an issue that we have been grappling with. I mean, we know disparities exist, and we're dropping genetics on top of it. So it's going to get worse before it gets better, unless we start developing a systematic approach that's also driven by evidence, and that evidence came up. And people ask, why isn't the U.S. Preventive Services Task Force looking at things? They did look at BRCA, they looked at other things, but we had a process called EGAP at one point, which is now kind of not sunset, but I think Katrina Armstrong was part of it. There's few people in this room, including I think other folks on that group. But the point that I wanted to raise is in the middle of sort of rapidly changing evidence and the need not to really do genetic exceptionalism, but taking care of all of us, and not all of us, the research project, but all of us. There are a few low-hanging fruits that the Roundtable has been working on in the context of the Genomics and Population Health Action Collaborative. And for those of you who don't know, this is a subgroup. It's an all-volunteer army that's been trying to get public health and healthcare systems to work together to begin to implement a few what we call Tier 1 genomic applications. I think people on the Roundtable are sick and tired of hearing me talk about Lynch syndrome, hereditary breast ovarian cancer, and familial hypercholesterolemia. But collectively, these account for 1 to 2% of the whole population. Okay, so it is 10 times or 100 times bigger than all of newborn screening. And newborn screening has become a public health issue because it's part of the rubric of all the 50 states. And, I'm not suggesting we're ready for population-wide screening for these 3 conditions, but we could. There are evidence-based recommendations that get into that direction, but not quite there yet. And we don't know how to implement them. So what is the role? I mean, we invest tons of money in finding new stuff, like all of us and other things. We don't spend any money implementing what we know. So there is this new science called implementation science. And I think Megan is in the room here. She's written a few papers on this. We've reviewed NIH portfolios. We've looked at the literature. And even in that Tier 1 space, we don't know how to do cascade screening, for example, for FH, because people live in different health systems. Those of you who talked about their health systems did not tell us how they're going to reach out to the relatives who may not be in the same city or the same state, after all. So we have a lot. I haven't even touched disparities. So just implementation with an eye towards disparity is the way to go. Now, the question that I have for all of you, because I don't think we have a chance to get this distinguished panel in all in the same room at the same time, what is the role of partnerships between the healthcare systems and the public health systems? Remember, we have 50 of them, 50 states, 50 public health departments, plus the federal government, other than the NIH, like HRSA, CDC, HRQ, and others, to try to deal with health disparities and evidence-based implementation to achieve health benefits at the population level. So take a crack at it.
One quick one is this issue that just came up around do you do testing in the face of clinical therapeutic futility? We know that a big part of the work, because of your work, Wayne, is the relationship between genetic and environment. So at least now you should be providing us, hopefully, with that ability to actually talk to a person about, here is your genetic profile. Here's what you are at risk for. Here is the relationship between your genetic profile and the environment in which you live. Now let's start talking about behavior. Let's talk about prevention at a different level of urgency than would have been before. So how do we start to smash that whole thing together? Now, in an ideal world, you would then roll that up even bigger by saying that if you are if you're in a value-based reimbursement world where you're at the delivery system taking risk, now you really have an incentive for every tool in the toolbox to try to, once the patient is identified at risk, to not have them tipped to being sick, because the sick part comes out of your pocket, and that's your profit. So now all of a sudden you start to get an incentive for that population, that community-based public health engagement with known concerns around genetic precursors that will hopefully be a part of the armamentarium of convincing that person, hey, maybe today is the day I actually do stop smoking.
I'm a big fan of collaboration, so I think it's a great idea, and I think, encourage you to also include the organizations that are out there in the trenches, as well as not just helping and partnering in how to implement it, but disseminating the results out to the community.
I work with a research network that is cancer in primary health, and there's people from England and the UK and China that are represented there. And this idea of siloing, here's Colorado and here's New York, and half the families over here, they just don't have to struggle with that, and we do. And I think that research networks have opportunities to, this is an example of how, when you're dealing with someone who's a mutation carrier, you're dealing with their family as well. And we have lots of opportunities to recruit families into this population so that we can understand them more and provide support. And speaking as someone who works in a public health system, a lot of times research opportunities and grant funding open up opportunities to improve access to care for entire families as well. So it's a difficult problem.
Yeah, I certainly agree with what you're proposing, that we should definitely expand our partnerships across the U.S. Also, keeping in mind that we should also think about expanding to partnerships through multidisciplinary teams, going back to like the, community health nurse model, where we, provide care to people not only in clinics and in the hospital, but in their homes as well. So I think these partnerships can be greatly beneficial.
So you guys, I know we're going over a little bit. We stand between you and a glass of wine or beer. I don't know. But let's go ahead. I'll do kind of what Greg did, which was like take the last 5 minutes and see if we can do like kind of quick questions and quick answers and get to some more people. So, John?
Okay, I'm just going to say, in response to what should future roundtables focus on, I'll give an example, I think, of what might not be a good one and what I think would. The first one that may not, might be focusing on who to test, and the reason, this I think would be the most debatable probably, but the reason I say that is because there are now companies with business models that are saying, we will provide sequencing entirely free because they will use the data and actually make their money on that. So it may not be, it may be very soon before the sequencing cost actually, or testing cost, is zero. Right, so focusing on who should get it, that might, be out of date by the time you get a lot of answers. The one that I think might be more valuable is how to return the results to the patients through mechanisms other than direct genetic counseling one-on-one, because there's going to be, if that first one is true, there will be so many results that there will be we're going to need a variety of other mechanisms to return the results. And I think all of us is focused or is struggling with that a little bit too, how to actually return it to the results, because there's going to be so much of it.
Thank you. Oh, there's nobody over there. Go ahead.
I know that this needs to be a quick question, so it will be. I'm Joanne Adelberg. I'm at ACMG. So my question has to do with really disparities and thinking about ACMG as being the, genetics organization behind many, genetic counselors as well as medical geneticists. One of the issues that we heard today is that the professionals who come in, the geneticists, genetic counselors, are just, I guess, overall pretty homogeneous. I think that's what I've heard. So in terms of a suggestion for the roundtable, it would be great if we could get feedback from you on how we can grow this population. What can we do to increase diversity? And, is it something in the schools? Is it something that we need to do with the community? How can we get this feedback from you on the appropriate way to handle this to get the diversity in the community, within race, within socioeconomics, and that's pretty much it. So,
if I can, real quick, do not take this as Otis Brawley says that we do not need diversity amongst genetic counselors, because I do believe we need more diversity. You don't need to have a black genetic counselor to work with a black person or a Hispanic genetic counselor to work with a Hispanic person. You need a person who cares to work with those folks. Now, that being said, I would love to see more diversity amongst genetic counselors. The community is incredibly small. Most of the young folks that I talk to don't even know what a genetic counselor is. As genetic counselors get a little bit more press, I think you may attract more folks. I don't have a really good answer for how to attract more minorities. I just don't want people to think you have to have a minority genetic counselor to counsel a minority.
I really think that's an important point. The other thing that may be worth thinking about, and don't go weird on me, but I think Mike Watson and the rest of y'all should go over and drop in on the Department of Education. I know there may be issues some of you may have with them, but at the end of the day, what if you're talking about and connected with commerce, and you start thinking about where are the jobs? I mean, this is only going to be a boom field for people to get employed. So why not start to just make it a big deal and say, give the administration a win? It's let them go ahead and say, hey, why don't you make a big deal out of training minority and other genetic counselors? It's a growth field. You can't lose. The investment in your education actually will return you value at the end of the day, and we're not going to run out of because there's 4,000 of you now? So, I mean, come on, we need 40,000. So at the end of the day, I would really just go ahead and knock on the door for commerce and education and say, time for y'all to get in the game. It's a win-win for you, and quite frankly, nobody loses.
Thanks. I just first wanted to acknowledge and thank all the researchers in the room and those who might be listening at home or in their offices who have taken the time to go in and do community-based participatory research, because it takes a lot of time and resources, and that's time that you could otherwise be conducting analyses, publishing papers, getting extra grants, but instead you're taking time, unfunded time, to go and do this in community. So really wanted to thank you for that. And from a population genetics perspective, I'm in the Bustamante lab, so I have the good fortune of being connected with a lot of current and former lab members who are world-class population geneticists, and many of them have said to me, we want to be able to have a full-time community liaison in our lab, but there's no way that there's any funding for this. So one recommendation I have for the roundtable, I don't know what level of advocacy you can do at NIH, but to really push funding mechanisms for population geneticists, clinical geneticists who want a full-time community liaison to be able to interface with those groups. And we know that the history of population genetics has contributed to a lot of this mistrust in these underrepresented communities. So the more we can really support those investigators who want to do this work, the better. And currently, I don't think there are any mechanisms. And if there are, I'd love to hear your suggestions so I can relay that back to the PopGen folks.
Any insight on that, guys? No. Jackie?
It's definitely needed from somebody that's in the community. We always need more help with, maintaining our relationships in the community, providing feedback to community members and to community partners. A lot of time, we don't have funding for that type of position. It really falls on the PI a lot of times. But it's really worthwhile. So this is something that you really have to be dedicated to. I wish there was more funding, and if you find any additional funding mechanisms, I'd be happy to work with you on that as well. But as of right now, I don't know of any funding opportunities to support community liaisons.
I guess the one comment I would make, there's several people from NIH in the room, as well as other federal agencies, so it's duly noted.
All right, you guys, we've run out of time. I want to thank the panelists for contributing to this discussion and for this session. It was fabulous. Vince and I are going to try to wrap up the day quickly, all right? So we'll see how that goes, right? We're going to move over to the podium and wrap up the day and have some closing remarks.